So good afternoon, everyone. My name is Megan Devine, as Kelsey so nicely introduced. I am actually a pulmonology and ICU physician, and I am up here in Tyler at the UT Health Science Tyler. I have had the privilege of working with Drs. Seaworth and Armitage for the last 3 years. They've been wonderful mentors, and I'm very slowly learning about the world of tuberculosis with their assistance. They asked me to talk today about chest radiology in pregnant women with tuberculosis. So I am not a radiologist like Dr. John, but all good pulmonologists read their own chest films. And so I'm sort of an very amateur chest radiologist. But I do like to talk about chest imaging and try to act as a resource for my TB colleagues in San Antonio. So the first thing I'll say is, well, is it gonna work? There we go. Technical difficulties. So I'm with talking to you about using radiology as a tool to more timely diagnose pregnant women with MTB lung disease, and then also to show you some radiographic manifestations of pulmonary TB disease in women. And let me just say a moment, I enjoyed getting ready for this talk because I got to read a fair bit, and I'll just note there's not a lot out there. This probably isn't surprising to anyone. Those of us in the research world like to stay away from pregnant women as much as possible. That's a very special population. So most of what I'm going to tell you today comes from several papers that are case series. They do span several decades, and then one meta-analysis. I have included the references in the slides in case you want to look them up yourself. So first, this probably goes without saying, but has been borne out in the data, is that TB disease in pregnancy is bad for both mother and for baby. And I'm going to talk purely about diagnosis and not about treatment. That will come in the next session, is my understanding. So TB in pregnancy. Active TB disease in pregnant women is consistently associated with increases in maternal morbidity, preterm birth, low birth weight, and perinatal death. And we know from looking at these sources that outcomes are worse for both mother and baby when anti-TB treatment is started late. So in one paper, they saw that neonatal mortality and quote, extreme prematurity were significantly higher in pregnant women with TB who started treatment later, which they did as after 25 weeks. These slides are figures taken from this meta-analysis by Dr. Sobey et al., published in the British Journal of Obstetrics and Gynecology in 2017, that showed that maternal morbidity, anemia, and cesarean section were significantly increased in women with active TB disease, with odds ratios as high as 3.9 and as low as 2.1 with good confidence intervals. You'll also notice that there is reported maternal death, antenatal admission, and miscarriage. Those did not meet statistical significance, but certainly I think would make all of us raise our eyebrows. This slide looks at the complications with baby, and you'll see perinatal death, low birth weight, and preterm birth listed there, with odds ratios of 4.2 and 1.7 respectively. There's also mention of acute fetal distress and asphyxia that did not meet statistical significance, but again, we would never want our babies to undergo those complications. So I think it's fairly clear that TB disease in pregnant women is bad for 2 patients, not just 1. And so I'm going to move on and talk that TB disease in pregnancy can actually be fairly challenging to identify, which makes it all that more important for us to have what I think of as very sensitive antenna when we're evaluating these ladies. So there's significant overlap between the symptoms of pregnancy and the symptoms of TB disease. And I think all of us probably have some degree of experience, whether we've been pregnant or we've treated pregnant ladies, that fatigue and malaise are almost universal. Poor appetite and breathlessness are also very common. And these symptoms can be seen and are seen in women who are pregnant and have TB disease. Now, there is a short screening tool that was validated by the WHO for pregnant women who have HIV co-infection. And in those women, the negative predictive value of a very short screening with 4 questions, basically, do you have symptoms of fever, cough, night sweats, and weight loss? If you have none of those things, the negative predictive value is very good. But you'll note that none of these symptoms of fatigue, malaise, poor appetite, and breathlessness in that tool. A significant number of pregnant women may be asymptomatic altogether and can only be found through screening. So several of these series highlighted this fact in various numbers. In the paper that I referenced there from CHEST, it was a very small population, but it was 5 women. They were specifically screened because of immigration status. This was in Rhode Island. And all 5 women who had TB disease were completely asymptomatic, but they were found through screening and had abnormal chest X-ray. The second reference there cited a 20% rate of patients who were pregnant with TB disease, but had absolutely no symptoms and were found through routine screening with abnormal chest X-ray. So not only are the symptoms vague and not necessarily indicative of pulmonary TB disease, but they may not be present at all. So again, we have to have a really heightened awareness of this possibility. And as I mentioned, in several series, all women with pulmonary TB had some kind of abnormality on chest X-ray. Now, what's interesting is a significant amount of the time, these are not the X-rays that we may necessarily think of in TB disease. So these tend to be more subtle findings, and I'll go over that a little bit more later, but unilateral disease, cavitary disease, small or indistinct infiltrates, and small effusions. Pregnant women may be more likely to have negative sputum smears and negative cultures. And that was highlighted in a couple of places. But these women who had negative sputum smears and negative cultures were picked up through chest X-ray. So they were identified as screening programs in at-risk population. Actually, most of them were immigrant populations in countries such as Germany, the UK, and Israel in the second paper listed here. And they were found because of targeted screening and abnormal chest X-rays. So once again, I'm not trying to belabor the point, but chest X-ray is important in this population. And I'll just take a moment too to mention there was in this paper from Israel significant delay in identifying women with TB disease who were pregnant because of hesitancy on the part of clinicians and other healthcare providers to obtain chest X-ray. Even though this was in the 2010, I believe the period from 2010 to 2014, somewhere in there, the healthcare providers did not want to obtain chest X-rays, even using shielding. And the women were identified later in their course once they developed symptoms that led to a chest X-ray, or for some reason changed their mind and had an X-ray at that point. So not only is it important in early diagnosis, but it's important in screening overall. All right, so this slide I put in here because I think these are 2 good examples of what I would consider more subtle chest X-ray findings. This group of people on the call probably see these right away because you're used to looking for things like this. Full disclosure, these are not pregnant women. I actually don't have very many images of pregnant women, neither does Google, I'll just say. But I do think that these are 2 really good examples. So the X-ray on the left of your screen, whoops, I'm sorry, my apologies. Highlight just this really nice right middle lobe infiltrate. You know that that's what that is because it minimally there shadows the right heart border. So that's a right middle lobe infiltrate. Not real impressive, but definitely there. And then the image to the right of your screen, that is right hilar adenopathy, which can also be a sign of TB disease. And I would say that if people are looking at these films quickly, you might miss those two things, but those would be important indicators in someone who had risk factors, positive testing, skin testing, IGRA, or certainly symptoms. So specifically chest x-rays in pregnant women. Very brief, I know no one really wants to talk about chest anatomy in pregnancy, but a couple of things you should remember or know is that in a pregnant woman, there's about a 50% increase in the costal angle. So everything kind of spread out. There's also an increase in the chest wall circumference and diameter. And ultimately, with a fully grounded uterus, the diaphragm position actually can move up as much as 5 centimeters. This may be different depending on where you are in the pregnancy. Then there are also some cardiovascular changes that do bring to bear on chest x-ray. The maternal volume can increase approximately 2 liters. That's going to change what the blood vessels can look like in the chest. Then your left ventricle increases its capacitance and its compliance, along with a decrease in the systemic vascular resistance. This actually allows our central venous pressure and wedge pressure to stay the same. Thank goodness, otherwise none of us could breathe at all. But what you can see as a result is some little generousness of the left heart border in particular. So the whole point of this slide is that it's okay to get chest x-rays in pregnant women. Dr. Armitage wanted me to make sure that I said that at least 5 times. So I think this is 1, but I'm going to try to get all 5 in. So chest x-rays in pregnant women are considered safe. There is something called the no adverse effect level, or the NOEL, that physicists and radiologists talk about. This is the threshold level under which the incidence of congenital complications or malformations will not be increased relative to the general population. So in other words, this is the threshold under which we feel like there is no increased risk of getting an x-ray to the fetus. So the NOEL, even at the most sensitive stage of development, which actually is the first 2 weeks. So this is post-fertilization and pre-implantation. The NOEL for that level is as low as 50 milligray, or in this reference, 0.2 gray. And I have a next slide that'll show you some more examples of the amount of exposure for each type of study. This website that I listed here is from the Health Physics Society website. I listed it just so that you would have it as a reference. This actually specifically deals with this topic, and you can actually ask an expert's opinion. There's also more information if parents or other clinicians wanted information to try to reassure them. Then we do recommend, in order to decrease the risk further, that we shield the abdomen and pelvis in any woman of childbearing age. Again, pre-implantation, we don't know that we actually are pregnant. So multiple places have cited the safety of chest radiography. I've listed a couple there on the bottom. Ultimately, the WHO has said that the use of shielded chest radiography in pregnant women poses no significant risk and does recommend its use in evaluating pregnant women at risk for TB disease. So the table on the left of this slide is the threshold exposure risk during the gestational and fetal period. I highlighted the highest risk time period, which is the 0 to 2 weeks after fertilization and before implantation. And if you take the lowest threshold that they reported, it's 50 milligray. If you look at the right-hand side of the table, those are different imaging modalities and the milligray exposure to the fetus. So chest radiography there, even on the higher end, is 0.01 milligray. So I'm just going to highlight this one more time. So lowest threshold risk is 50 milligray. One chest x-ray is 0.01 milligray with the shielded abdomen. So I hope that's enough to reassure everyone that chest x-ray is safe in pregnancy. Just shield the abdomen and move on. please. Good news though, you don't need to be a brilliant radiologist because pregnant women's chest x-ray looks just like non-pregnant women's chest x-ray with very rare exceptions. You may have increased vascularity, you may have enlarged pulmonary artery shadows, and you may have a mildly enlarged cardiac border. You may have elevated diaphragms, you may have smaller lung volume. Incidentally, I'm sure if you guys thought about it for a minute, you've seen plenty of x-rays that look just like this, only they're not pregnant women. They're older people that are women or men who have some adiposity and aren't taking a deep breath. So you've seen films that look like this all the time and you're still able to spot TB. Chest x-rays of pregnant women with TB disease may have more subtle findings. So like I mentioned before, you may have less fibrotic disease, you may have less cavitary change. You may have these subtle infiltrates, adenopathy, or small effusions. And the way that you're going to pick these things up is just having an increased radar for little findings. And we have all kinds of different terms for them, those of us that look at films all the time. Dr. Armitage likes to call them nib-knobs. I call them ditzels. But if there's any question at all, I encourage you to ask someone else to look at it. Or to go back to the patient and just think harder. Little things, pregnant women may be something important. This slide is just an example of a non-pregnant woman chest x-ray. It's a nice normal chest x-ray. If you really want to nitpick, there's a little bit of tenting of the diaphragm, but it's okay. So in comparison, here is a woman who is 27 weeks of gestation. There is note there that the shield was used. And you might pick up that the vascularity is a little more prominent than the previous film. You might pick up that that left heart border, kind of where the atrial appendage is a little more generous than you would expect for an otherwise young, healthy woman. So I've just highlighted those changes there. Perhaps the right pulmonary artery shadow you might mistake for a very subtle infiltrate change now that you have your antenna really tuned for any kind of findings. If you looked at this film in the lateral projection, and I'm sorry I didn't include it here, but you could very easily tell the difference. So I do highly recommend that you obtain both PA and lateral films for that reason. And I'll take a moment too to just briefly mention, if you, in the right upper lobe there, if you were concerned about something sort of hiding in the right upper lobe behind the clavicle, you might obtain what are called lordotic chest x-ray views, which gives you a better look at those upper lobes behind the clavicle. And again, one more chest x-ray is a tiny little bit of exposure that is not felt to be harmful to the fetus at that dose. So I included this quote because I think it's very timely and it really dovetails very well with talk. So this was on the chest paper in 1994. It says, if routine screening is not performed prenatally with radiographic follow-up of infected individuals, most pregnant women with TB will not have their conditions diagnosed, and therefore they will not be treated in time to prevent risk to the fetus, the newborn, and the obstetric ward. And this was based on a small series of pregnant women who were screened as part of an immigrant population in Rhode Island. And that was a number of years ago. So I think this is very helpful to keep in mind as we go forward. Now, I realize that was pretty brief, but I felt like that was the high points. I'm happy if there are any questions about what I've said so far. If not, we'll go forward. I think these cases discussion will further highlight the importance of having that really finely tuned sensitivity and obtaining chest x-rays for our ladies. And Chelsea, I'm terrible with this chat screen, so if you see something that I don't see, please give me a shout.
I got my eyes on it for you.
Thank you. I tend to just barrel forward and I forget about that whole box. So these cases, I have to say, they come from Drs. Armitage see work, because thankfully I've really not had very many pregnant patients myself with TB disease. The couple that I had, the images weren't very good, and so I didn't think they were going to prove the point very well. So Dr. Armitage and Worth, please stop me at any point, correct me, add details, whatever you need to do to keep me on track. I absolutely take no offense. So the first case, this is a young woman, this is Dr. Armitage's case, who was identified postpartum. And unfortunately, I think you're going to see a theme in 3 cases. Part of the reason that I use these 3 is that I want them to be examples of how we should find women before they get to this point. This is a young woman who's identified postpartum, and she identified because her child became ill. So her newborn infant became very ill. And before I show you the x-ray, I just want to give you a little bit of background. So this woman, check my notes. She gave birth to her child via cesarean section, and she was delivered early of her child because the child was found to have in utero had abdominal ascites that was picked up on ultrasound, and ultimately the infant was delivered early and then was very seriously ill, and at Children's in San Antonio, I believe, was found to have TB disease based on tracheal aspirin. So sort of a backwards contact investigation. I think there's a term for this. Please correct me, Lisa. But identified this woman had absolutely no symptoms. She had a chest x-ray. And this is her chest x-ray. Let me see. I'm not sure if this projects very well. Chelsea, can you see my mouse?
Yeah, we can see it.
Okay, good. So this chest x-ray might be a little deceiving because you don't really see anything in the lung fields, and that's where our eyes always want to go. But what she has here is this subtle finding of blunting of her right costophrenic angle. And then this little thing that kind of sticks out right here, that is something I would read as probable pleural thickening or perhaps a very small loculated effusion. And if you look on the lateral, you see this little area right here, a little bit abnormal, certainly not strikingly so. But because her infant had congenital tuberculosis, this is concerning for active TB pulmonary disease in this woman. And further history was obtained and discovered that she's an 18-year-old, otherwise healthy young woman who was born in the US, but had traveled to Mexico for some time. Turns out that she had had a febrile illness approximately 4 months prior with night sweats, and it resolved on its own. She also had a maternal grandmother who had tuberculosis. So she was treated with improvement. The child details I will leave to Dr. Armitage, but important to point out here that most likely what happened is she had transient mycobacterial bacteremia during that febrile illness, which would have exposed the placenta, either through lymphatic or bloodborne exposure. I don't know if we would have caught this woman in particular because she really didn't have any known risk factors. She wasn't in a particular population to be screened. And we didn't catch her during that acute febrile illness, not sure if we would see anything graphically. But I think that she most likely, probably, maybe, please correct me, could have had a positive test or a positive IR. I get questions, so I'm going to come look at this. So that's a good question, Cindy. So the question, I'm sure everyone can see it, is there a reason smears and cultures are commonly negative? So I'll tell you the little bit that I think, and then I'll certainly open it up to my colleagues that have more knowledge about this. But it's interesting, women in general, if you look at women versus men, women cough less than men. So, and this bears out in the tuberculosis population, but also in the non-tuberculous mycobacterial population. There's a couple of old papers that talk about this just very briefly. We certainly see it in the NTM world that women just don't cough as much, and when they do cough, they don't produce as good of quality sputum. And at least for those of us NTM, you know, we all go back to the Lady Winters phenomenon, where it's really not ladylike to cough, and it's certainly not ladylike to cough up a big old loogie. There may be immunologic phenomenon involved in that as well. It's a source of research in the NTM world. Dr. Armitage, do you have any comments about that, or Dr. Seaworth?
I think more so of what it is that you've explained is not really I think a lot of times, unless there is, you know, severe disease in the ladies, they're not really looking for them. A lot of times TB is diagnosed once the patient has delivered already. There's just not a strong will to do a lot of investigations until the woman is given birth. And I think you may see a little bit more symptomatic, more validation of symptoms once the woman is delivered.
That's a good point. Okay. Dr. Seaworth, this next case is yours. So this is a woman who was identified postpartum when she became ill. I don't have as much detail about her, but she is a woman who is of Indian origin, and she had had a cough for 6 months prior to delivery. I don't know if that was ever discussed with healthcare providers, but after she delivered, and she did deliver a healthy baby, she developed worsening cough. And Dr. Armitage, this may be to your point, maybe her cough was worse, or maybe it was just that it was noticed more, as well as fever. And for those symptoms, she had a chest x-ray. Now this one is not subtle. So now who knows what it might have looked like 6 months prior. There certainly obviously would have been disease, but it may not have been as obvious. And her sputum grew out at MDR TB isolate, for which Dr. Seaworth treated her with very nice effect. So here's her follow-up chest x-ray, which I consider that success. Congratulations, because that follow-up chest x-ray looks really good. Dr. Seaworth, do you have any comments about that?
No, I think, well, oftentimes patients will actually get worse in the peripartum period, and just because their immune system ramps up and they have more of an inflammatory response. So that may explain the bigger and more predominant cough. They may also just be able to breathe better and take more air into their lungs and be able to cough more effectively once they've delivered. I'm not sure with this particular woman, but we did try to go back. She had moved in the context of when she was in prenatal care to when she was about to deliver to a different city. We tried to go back and notify folks to do contact investigation around her providers and community where she initially lived, and I never learned the results of any of that. Had very few contacts in her new community, and other than her immediate family, we didn't find any other latent infection or active disease.
Okay, thank you.
I wanted to add one other thing. The chest x-ray that you showed at baseline before she was treated, that's only 8 days postpartum. So I feel very confident in saying during the last part of her pregnancy, much of that lesion was likely there while she was still pregnant. So this isn't this was not a long time postpartum. It was 8 days. So now we have a baby that she's been breastfeeding for the past 8 days with MDR TB and that chest x-ray.
No, it's an excellent point. And I'm going to assume she grew quite a significant microbacterial burden with those multiple cavities.
Yes, she did. And she was smear and culture positive for some time.
She has quite a bit of disease there. So I see a couple of questions. So the first one was, is there any difference in risk to the baby, the location of disease within the chest, from Claire? In other words, does one area of disease confer a higher risk than another? I could not find anything to that effect. Now, there is more risk if the woman is HIV co-infected. And there was a tiny little bit about pulmonary disease versus extrapulmonary disease. The extrapulmonary disease was more common in women who were HIV co-infected.
So I think what I have seen, and I don't have a reference to just document that right now, but a woman that has either disseminated disease or who has general urinary disease. And so we've seen that especially in women who have had in vitro fertilization, and they have involvement of the general urinary tract, but not necessarily pulmonary disease. And they oftentimes can have quite negative outcomes in both themselves and in their infants. And so that may be where the general urinary involvement comes from, as being associated with more likelihood of baby being infected. And that's a whole nother talk, actually.
Yeah, that's a whole nother talk, right?
Yes.
Okay, let me look at this. Yes, and so just a comment. Yes, if primary disease cultures and AFB smears are commonly done, right, because it's low bacillary load. Okay. So I feel like so far we've kind of highlighted there can be opportunities in the prenatal period. And this last case, I think, sort of tells its own story. And again, please feel free to stop me as we go along. I think there's multiple missed opportunities, but also areas for us to think about going forward so that we can prevent another case like this from happening. And please, Dr. Seaworth and Dr. Armitage, I know you took care of this woman, or at least were involved at some point, so please feel free to interrupt me. So this case is a pregnant woman. She was in her 30s. This was not her first pregnancy. This was actually her 5th pregnancy. And she came to attention due to a positive skin test that was 35 millimeters. And this was obtained while she was incarcerated. And she was reportedly asymptomatic at the time with a negative chest X-ray. The plan was to treat her as a latent TB infection postpartum. So she's identified in the first trimester, and we're thinking about treating her 6 months down the road for LTBI. And just additional information that you might want to know, HIV status was negative. She had no known TB exposures, but she had been incarcerated before. She did not have a previously reported positive skin test. It's unclear if she had one and it was normal, or she did not have one at all, which obviously would change things a little bit. And so I'll just stop there. And are there any red flags, anything anyone wants to comment about before I go to the next phase? Okay. So now in her 3rd trimester, she is out of incarceration and she's working in a pawn shop. She has an ankle monitor. And it seems that she is getting some prenatal care. She does have appointments, and she's reporting fatigue. She's noted to have tachycardia, worsening anemia despite iron supplementation. And I said no weight gain here, but not only no weight gain, she's lost a kilogram. You know, if you take into account fluid changes and whatnot, maybe she hasn't gained weight, but at 15 weeks, she was 65 kilograms, and at 34 weeks, she was 64 kilograms. And she reports a headache 2 weeks prior to delivery. So can we consider all of these things normal in a 3rd trimester pregnancy, or are there things here that might make us pause? I know that's a rhetorical question, right? So fatigue, yes. Maybe headache, be a little headache, maybe a little tachycardia. But the worsening anemia and the no weight gain and the weight loss, absolutely. So unfortunately, whoops, oh my gosh, you guys, I should not be able to drive. So the next phase is at 36 weeks, she has a premature rupture of membranes. So here we see a baby that's somewhat early. She is ostensibly healthy, weighs 5 pounds and 5 ounces. So a little small, but nothing terribly concerning as I understand it. And the mother is afebrile. Her hemoglobin is 7.8 and her platelets are 653,000. And she leaves no further care at that point. At weeks postpartum, she is now again incarcerated. And now her skin test is 0, with the previous skin test, as you recall, being 35 millimeters. While incarcerated during this period, she has multiple visits to medical services. And she's reporting symptoms of fatigue, night sweats, shortness of breath. And she's found to have tachycardia, low albumin, and low hemoglobin. And Dr. Seaworth, was there any mention of any further evaluation at this stage?
Not anything other than what is noted here.
Okay, that's what I thought. I just wanted to
They're
make
just
sure.
kind of scratching their heads. And I think there was, in talking to her mom, there was a lot of kind of not believing of her symptoms.
Okay.
Ignoring of her symptoms, ignoring.
Okay, that was my impression. I just wanted to confirm. So at 7 weeks postpartum, she goes to the emergency room with fever to 103 degrees Fahrenheit, cough, and continues with the same constitutional symptoms, the fatigue, the night sweats, and the shortness of breath. Now, unfortunately, she tested positive for COVID, and we can all talk a long time about COVID's effect on patients with tuberculosis and other medical illness. But be that as it may, this is not her chest x-ray, but it's very close to her chest x-ray. She had a lovely one, but it didn't project very well. This is very, very similar. So the report was bilateral infiltrates consistent with COVID-19 infection. And I'll just say that it's not like any chest x-ray I took care of, and I took care of a lot of COVID-19 infected patients. But this pattern is certainly diffuse and is nodular. You might imagine that there's these tiny little, almost look like rice grains that somebody threw at this chest and stuck. And then she also has this blunting of this left costophrenic angle, which would suggest a little bit of left pleural disease there. Don't see pleural disease in COVID-19, incidentally. So she had this chest x-ray that was attributed to COVID-19 along with her other symptoms, and she was sent back to jail. At 13 weeks postpartum, she was then admitted to the hospital with fever, hypoxia, tachycardia, and intermittent bowel and bladder incontinence. She had too many serologic abnormalities for me to list here, but they were all consistent with a person who is in fully decompensated severe sepsis. She had a positive quantiferon, and then she had a positive sputum and urine AFB smears. These later were culture positive as well. 4-drug RIPE therapy was started 4 days after she was admitted, and she had a cardiac arrest overnight and expired the next day. So I think it's very obvious that this woman had multiple opportunities prenatally and postpartum to have intervention that would potentially have been life-saving. Certainly we could have caught her back when she had a positive skin test and evaluated further, perhaps treated her LTB at that point, we'd have a different story to tell. Or even if we could have caught her when she started having weight loss and those other symptoms even before she delivered. And treatment, like I said, will be talked about in another day, but in this case, I think hopefully we would have identified her and treated her and not had this outcome. Dr. Seaworth, is there anything else you wanted to mention specifically about her? I can't imagine how hard it was to be involved in this.
Yeah, it was really very, it really bothered me so much for many, many months. And when I see her case again, I am really bothered again. You didn't show it, and probably it didn't project, but at the time she delivered, she had this massive breast abscess that was actually required surgical intervention and debridement. It was very deep. It was loculated. All cultures were negative. And at the time of death, the abscess was still open. And it was very likely a tuberculous breast abscess. TB grew out of every place in her body. Her lungs, her bone marrow, her blood, her, abdomen, and then she actually herniated, which was her final event.
And as a learning point, I didn't run across so much about breast abscess in the United States, but certainly in other parts of the world, tuberculous breast abscess, mastitis in postpartum women is a significant phenomenon.
Yeah, and she actually presented, she had the breast abscess at the time she delivered. So it actually developed before delivery, which is, again, suggests it's not mastitis, but somehow in the, some of the notes, I think that was missed by people who took care of her later. But we've actually had a number of breast abscesses that we've encountered both in our clinic and in our consultation service, and that have been admitted over at TCID that are part of pretty disseminated disease most often.
My apologies for ending on such a sad case. I was really was wanting to use it more as a tool. Maybe I should have done this one first.
If you have a second, Dr. Cruz made a point about she's a pediatrician and has cared for infants, of mothers who were infected during pregnancy, and I wanted to invite her to share her experience with infants, with her congenital TB infants.
Absolutely.
No, thank you, Lisa. So I've taken care of 3 kids so far. One was a mom who, in retrospect, TB should have been higher in the differential from the beginning. She had multiple miscarriages, I think 8 or 9 miscarriages, and was finally able to carry a baby to term. And what likely happened was at the time of delivery, when membranes ruptured, the child just inhaled this enormous inoculum of AFB. She actually presented in the first week of life with symptoms. She had massive hepatosplenomegaly. She had biliary disease. She actually did not have meningitis, but she died of bronchiolitis obliterans 9 months after starting her on treatment. We had another child whose mother had, really what looked for all the world like, some of the chest X-rays that you just showed, with a very subtle pleural effusion. And that child had a cold liver abscess, definitely had mycobacteremia. She actually grew TB from multiple cutaneous lesions. And that child has such enormous hepatosplenomegaly that she actually had to lay in her motor milestones because she could not physically roll over because her liver and spleen were so large. And that child actually did quite well. And then we had another child who also had miliary involvement following this. And sometimes, it is challenging to determine, was the transmission intrapartum or was it in the immediate postpartum period for a mother who might have had cavities and was breastfeeding, for example, because it's harder to think of, a situation where one would be better positioned to give an infant TB. But I think, the hallmarks in these kids is that the incubation period is just so ridiculously low. It's within the first 2 to 3 weeks of life for congenital TB. And, I really worry about this idea of we're just going to wait till the women have delivered in order to get them hooked into care. Because for so many women, the only time that they have reliable access to healthcare is when they're pregnant. And the moment they deliver and they finish their postpartum care, it's like, you know, those women lose access to the healthcare system. And I also really worry about if you have a mom and you're saying, you know, we want to treat you, this is important, but it can also wait 8 months.
Right.
What message does that send to women about how important this is if you can punt treatment to several months down the road? And I recognize, you know, the rate of, you know, hepatic involvement or hepatotoxicity with TB meds might be higher in pregnancy, but I do think it's a question, just like, you know, getting a chest X-ray in a pregnant woman. It's all about weighing the risks and the benefits. And for all 3 of my patients, by the way, the first person in the family diagnosed was the baby. So the kids are very much the proverbial canary in the mine.
Thank you, Dr. Curtis. Dr. Armitage, any other comments?
No, I think, you know, the points that we're making, you know, and I appreciate it. I think you did get close to the 5 times I asked you to mention that chest X-rays are safe. And, you know, I think we're all tying in the same theme that you can save 2 lives by being, you know, by considering the pregnant woman when there is reason for evaluation, even, you know, beyond screening. The chest X-ray, it has so much value to add, being fearless in protecting that woman and her baby. I think that's what we're hoping that everyone will take away from here today.
Thank you very much. Chelsea, shall I stop sharing and turn it back to you?
That sounds like a plan. If you could stop sharing, and then we will have Dr. John come on, and she will be talking about our radiography in infants and children. There we go. And Dr. John, whenever you're ready.
Unmute myself, sorry. And start my screen so you can see me here. So this has really been very interesting today because I don't often get to hear about what happens to children before they're born, so that have TB as a radiologist. And so I know a lot about the imaging of the chest and of TB, not so much about the management, and so I'll rely on the other panelists to help me with that if you have questions about that. But today I'm going to really show you, I have no disclosures, by the way. I'm going to show you some of the imaging findings that we see in infants and children that have TB, and talk a little bit about how we can sometimes differentiate TB from other conditions that have very similar findings. And I will also show you when advanced imaging is an important tool to use, although I will focus largely at the beginning of the talk here on chest X-rays, which is one of the major tools, of course, that we use. Imaging is really important. It really augments all the other clinical tests that you have available to you for TB. And almost any system can be involved, but mostly in children, we're worried about the chest because that's the primary place that we tend to see the pediatric forms of TB developing. And since we have multiple types of imaging that we can use, we often do use them, but mostly we use them more for management of complications of TB than for the initial diagnosis of TB. There are some challenges with the imaging of TB. Some of the findings are variable between patients. Many of them are pretty nonspecific and can happen with multiple other types of diseases. Interpretation of chest X-rays is a little subjective, and not all radiologists in the world are that comfortable with pediatric chest X-rays. So pediatric radiologists have special expertise in that area. And then depending on where you're practicing, some imaging is expensive, may not be available, and the quality of the imaging is really, really important to make sure that you can find the findings that you want to see. I will refer to sort of the classification that we've tended to use, which is primary TB, which predominantly occurs in children, and post-primary TB that's much more common in older children, adolescents, and adults. But really, there's been a blurring of the patterns between children and adults over the years. And so you can see both types of disease in both children and adults. And so I think the preferable way to think about the radiologic findings of TB is really to think about the location of the disease and the type of lesion that you're seeing, whether it be lymphadenopathy, parenchymal disease, miliary disease, cavitary disease, pleural disease. And I'll show examples of all of these. So thoracic tuberculosis in children really reflects the progression of the infection that you already know about. You get a lung focus, it drains to the regional lymph nodes, and then it can spread widely, either due to intrabronchial spread or penetration of some of the adjacent spaces, or to a widespread hematogenous dissemination. But the primary focus is usually pretty subtle. That pulmonary focus, which we call the Ghosn focus, is usually just a small area of focal airspace opacity. And it's often very transient. Sometimes it'll be hidden by the cardiac silhouette or the liver. And so you may not see it on chest x-rays, or it may be gone by the time you think to get a chest x-ray on a child for TB. Pleural effusions can happen, but usually they're pretty minor in the early stages of pulmonary TB. And so this focus will tend to rapidly go away. Sometimes you'll be left with a small nodule there, which is a granuloma, which is sort of the benign residua of that Ghosn focus. In some children, maybe as much as 25% of children, they'll have a little less ability to control the infection in the lung. And so you'll get a much more pneumonia-like picture. You'll get a focal area of airspace opacity like you see in this child. And that opacity doesn't look really much different than most types of pneumonia. So you may not have many clues just from its appearance as to the fact that it might be TB. And it also can extend up to the hilum and make the hilum difficult to see. And that's pretty important because really the hallmark of primary TB or of TB in children is going to be the detection of lymphadenopathy in the chest. And really you can see abnormal lymph nodes in the majority of children that have TB after about 1 to 3 months after infection. It's going to be much more common in young children, particularly children under 3 years of age, than it is in older children. And it's pretty hard to see in some cases. And so we look at the chest x-ray, we don't always agree as to whether there actually are lymph nodes there or not, because they occur in subtle places in the chest. So I'll reiterate what Dr. Devine said about 2 views of the chest. I think it's really important if you're looking for TB to always get 2 views of the chest. So where do we look? Well, mostly where you're going to see lymphadenopathy in the chest, you're going to see it in the hilar regions here, because infection in the lower and middle lobes of the chest tend to drain to the hilar nodes, or you're going to see it in the paratracheal region, predominantly on the right, which tends to be where the drainage for the upper lobe goes. Now, when you look at a chest x-ray, you may see a lot of stuff in the hilum, and it may look kind of bulky to you. Often the vasculature makes us be concerned that we might have too much there. But if you look closely at this right hilum, notice that those vessels sort of branch out and you have a concavity between the vessels. And that tells you that this is all just vascular markings. Branching things that radiate out from the hilum are just vessels. When you look at this patient, you can see, well, that hilum is pretty indistinct, and it makes it pretty difficult to see the vessels. So then you don't really know, do you have lymphadenopathy in there or not? And these are the kind of cases that can be very, very challenging, because you can have similar parahilar parabronchial opacities in a child that has a simple viral infection. And so you're not going to be necessarily thinking of TB just because you see this pattern. This patient is a little bit easier because there isn't a lot of parahilar opacity here. You've mostly got your vessels, and then you have this convexity in the region of the right hilum. And that's very different than the left hilum, where you have the normal concave appearance to the vasculature. So this is what you expect to see if you have hilar lymphadenopathy. You expect to see a rounded contour that pokes out from the hilum in this way. On lateral view, which is really important, because if you see something that looks prominent on the PA, you're going to need to look at the lateral view and make sure you can see it there as well. Beware of the pulmonary artery, because it projects as a round structure anterior to the carina region. So don't mistake that for a lymph node. Lymph nodes are best seen on the lateral chest x-ray, either in the subcarinal region, this is a big lymph node in the subcarinal area, or sometimes in the retrocarinal region. Those areas shouldn't really have anything that looks nodular or rounded. And so if you see anything there, you're probably dealing with abdominal lymph nodes. So here's just a comparison of lateral views. You can see on the normal side, once again, concavity in the region of the branching vessels, whereas on the side with lymph nodes, or the child with lymph nodes, you see the rounded nodular opacity in that subcarinal region. Sometimes the hilar aren't that easy to see. This patient is a little bit turned to the right, and so that causes the mediastinum to be thrown out, and it's pretty hard to see that you have a rounded concavity there, but looking on your lateral view, you can definitely see there's too much density there, too much nodular density, probably have lymphadenopathy in the chest. The left hilum is particularly challenging. And so it's often said that right hilar lymphadenopathy is more common than left, but I don't think that's true. I think we just see it better when it's on the right side. So this child initially, you really couldn't see much in the left hilum, but when we got a repeat x-ray, it was better positioned. And now you can see that there's some convexity and prominence on that left side that was the left hilar lymph nodes. So how do we improve our detection of lymph nodes? Well, certainly CT does better than chest x-rays in most cases, a lot better in some cases. But we don't really like to do CT that often in children's chest if we don't have to. The radiation doses have come down for CT, so they are pretty safe, but still, really it's only indicated when you really have to make a difficult management decision, or if you have a patient who is in a very high risk group, then CT becomes important, and you shouldn't be afraid to get it if you need it. But we don't use it as a first line diagnostic test very often at all. If you're going to do CT, you've got to use IV contrast, because you need to enhance the pulmonary vessels so that you can distinguish those from lymph nodes, because they will look exactly the same on a non-contrast CT scan. High resolution chest CT is available if you really want to look for the tiny miliary nodules. That's a good way to see them. I find that anybody that orders a chest CT these days tends to order it as a high resolution CT, but really high resolution CT is a very specific protocol, and it's not something you can really do in young children, because the patient has to really hold their breath, have a deep inspiration, and unless you put the patient under general anesthesia and suspend their respiration, you're not going to be able to do that. So a regular CT scan of the chest is usually good enough for most findings on CT. And this is just an example to remind you why you should not order it without IV contrast, because you cannot distinguish the heart and the vessels and the lymph nodes and all of the lung disease from one another. They're all soft tissue density, and you can't tell what's going on there. MRI is actually a pretty good thing to do. There are a lot of benefits to it. It's very good for mediastinal lymphadenopathy. Certainly anything over 7 millimeters is going to be easy to see. You can see pulmonary consolidations, and you can see some pulmonary nodules if they're big enough. And it's very good for pleural effusions as well. The problems with MRI is that it's expensive. It's not available everywhere. For young children, you're going to have to use sedation or general anesthesia to really accomplish it. And actually, if you look at the image here, you can see that left lung, you really can't see much detail in the lung. So fine detail in the lung is not well seen on MRI at all. So we only use it if we have real questions about mediastinal disease for the most part. The sites that you will see lymphadenopathy is almost everywhere, but a large number, a percentage of patients will have subcarinal or hilar or paratracheal, particularly right paratracheal lymphadenopathy. And the majority of patients will have lymph nodes in multiple sites. So looking with CT, you're much more likely to be able to see all of these sites. So where do you look on CT? Remember that the thymus gland is prominent in young children, and although you can get anterior mediastinal lymphadenopathy fairly commonly in some patients, it won't look like this. This is just homogeneous, normal, prominent thymus gland in a young infant. But where we do have lymphadenopathy here is, you can see here in the subcarinal region, you have bulky nodes, in the right hilar region between the enhancing vessels, and also in the right paratracheal region and the retrocaval location. All of those are areas where you should look closely on a CT scan for lymphadenopathy. The size criteria is really not well established, but generally we consider any lymph nodes that are over 1 centimeter to be abnormal. If they're under 1 centimeter, they may still be abnormal, but not necessarily, because children do have a lot of lymphatic tissue and get a lot of mildly enlarged lymph nodes for a variety of reasons. TB nodes can continue to get bigger and bigger over time, so got to be aware of that. And the appearance of TB nodes is a little bit variable. The classic appearance is what you see here, is that you have some peripheral enhancement with a more low attenuation center because of the caseation and necrosis that you get in the central portions of these nodes. That's a characteristic finding, but it's not really pathognomonic. You can see that with other types of infection. You can even see that in tumors in some cases. Often you'll just see homogeneous enhancement of the nodes, and rarely in pediatric patients you'll see calcifications, although calcifications are much less common in the nodes in children than they are in adults. Just a cautionary note is that lymphadenopathy does occur in other infections, in particular mycoplasma. My mentor when I was in radiology always taught me that if you're thinking primary TB and you see lymph nodes in the chest, the next thing you've got to say is, well, it could be mycoplasma, because they can look very similar on chest x-ray. Other fungal infections are also a pretty common cause of peripherally enhancing lymphadenopathy, such as coccidiomycosis in this patient. In our part of the world, histoplasmosis is probably the more common thing that we see, but many types of infection can cause this kind of lymph node. Calcifications occur in the areas of caseation, and usually they arise anywhere, up to about 4 years after the infection. So you're really not going to see these in infants and young children very often, although calcification tends to occur a little bit earlier in young children than it does in older children. But mostly you're not going to see them, and when they're there, they're pretty hard to see. This was an older pediatric patient that came in with an area of atelectasis in the right upper lobe, and it wasn't really clear that there was lymphadenopathy on this chest x-ray, but the CT very nicely showed these tiny stippled calcifications in the region of the paratracheal and subcarinal lymph nodes in this patient. If you want to see calcifications, you should put the CT scan on the bone window, because bone windows look for calcium. And so that's what we're looking at here. You might miss them if you have a contrast enhanced CT and you don't look on the bone windows. Lymphadenopathy can also be hidden by the thymus gland. So in young children, such as this one, you see a bulge in the paratracheal region, but you really don't know whether that's normal thymus gland or whether there's lymphadenopathy there. So that's a time when CT might be of benefit. And here we can see the enlarged lymph node behind the cava. There's really not much thymus gland in this young child. It's more atrophic, and you can see the stippled peripheral enhancement that's fairly characteristic for tuberculous lymphadenopathy. Complications are often the result of the lymphadenopathy. in children. Often it's related to airway compromise, which is sometimes due to the lymph nodes causing extrinsic compression on the airway that can either cause partial obstruction of the airway or complete obstruction, which will result in atelectasis. And for some reason, this tends to occur more commonly in the left lung than on the right. You can also have endobronchial occlusions, either due to granulomas that develop in the bronchial wall, or to caseous material that just plugs up the airway. But in any case, you'll tend to see atelectasis. Atelectasis is common in children with a variety of infections anyway, because their airway is small and easily compromised. And atelectasis is sometimes subtle. Here you can see sort of an ill-defined area of opacity on your PA view. It isn't really clear what's causing that. When you look at the lateral view, you can see it's a little more streaky, and if you look at that linear opacity here, that's the oblique fissure that's bowing towards that opacity in the lung, which means there's loss of volume there, which means it's atelectasis, it's collapsing in the lung. So two views, once again, it's very important to be able to tell a developing consolidation or airspace disease in the lung from just simple atelectasis. This child had prominent bulky lymphadenopathy in both hilar regions. I think you wouldn't have trouble seeing that. Came back a month later, and now you can see that there's a dense area posteriorly in the left lower lobe here that has some bowing of a segmental marking here. So this was atelectasis that developed somewhat distant to when the diagnosis of TB was initially made. And this went on to be progressive and to completely collapse that left lung a week later. So these are complications that do not occur immediately necessarily, but can occur well down the line after the initial infection. Obstructive emphysema is related to a partial obstruction of the airway, which allows air to get in the lung and not out. You can see that there's a prominent lump here in the left hilum, that's hilar lymphadenopathy. And if you look at the lung on that side, you can see it's bigger, more radiolucent, darker. The vascular markings are less well seen on that side, and that's because there's too much air on that side. So there's air trapping in that lung related to this lymphadenopathy in the hilar region. And if you look closely, you can actually see the narrowing of the bronchus that's resulting in this air trapping on that side. So it has been said that there's a pretty strong association of this type of lymphadenopathy causing airway obstruction with TB, although not everybody is all that good at detecting that. So, but it is one of the complications you'll see quite frequently. What we have always called post-primary TB tends to be much more common in teenagers and adolescents, and it has a more typical appearance of what you tend to see commonly in adults with TB. Opacities in the apical segments are most common because of the low oxygen tension in those areas, and you can get the typical cavities and ongoing fibrosis that you're familiar with. Cavitary disease has very specific appearance in that cavities are air-filled spaces. There are areas of destruction in the lung. So you're going to have a cavity and you're going to have air in it, and the surrounding tissue is going to tend to be quite thick. So most cavities have very thick rind. And also because they're areas of destruction of the lung, they tend to not go away. They tend to be quite persistent. The area, the air may get resorbed eventually and it may collapse, but sometimes you'll have long-standing cavitary disease in patients. But air-filled cavities can also occur in children with primary disease. Here's a child with airspace disease related to primary tuberculosis. And you can see over time some cystic air spaces began to develop within the middle of this, and in the end, quite a bit of cystic airspace disease was seen in the middle. And so there are really two types of cavities. There's the type of cavity that is persistent and is due to bowel lung destruction, but also there are nematoceles, and nematoceles are really just small areas of focal air trapping within the lung due to plugging up of the small terminal bronchioles and end bronchioles. And these can be, and generally are, self-limiting. So over time, these will tend to go away. And you can distinguish these usually because they tend to not have so much surrounding airspace disease, although you certainly can see it in the acute stages like this patient. But notice that the wall is very thin with this nematocele, which is, it's much more characteristic of a nematocele than a cavity. This was a child with congenital TB who at discharge had these really terrible looking lungs with all of these very large cystic airspace diseases that look like they could be cavities. I really didn't have much hope that this lung would ever look better than this. And I was quite surprised when this patient came back 6 months later to see that most of these, in fact, all of these airspaces had gone away. And there was a little bit of scarring left or a little bit of atelectasis in their location, but many of these were either bulla or more likely nematoceles that collapsed as the child recovered from the disease. Disseminated TB is quite common, particularly in young children under the age of 5 or in immunocompromised patients. It can be pretty hard to see in the early stages because the miliary nodule traditionally is less than 2 millimeters in size. That's size of a millet seed is why they call it miliary. But be aware that in children, sometimes the nodules can actually be larger than millet seeds, so that you can have more nodular or ill-defined opacities that are still related to miliary disease. It's usually bilateral. It's usually evenly distributed throughout the lungs, as you can see in this patient. Be aware that this same kind of pattern can happen with a variety of other conditions. Certainly other types of granulomatous disease can cause this, including sarcoid and fungal infections. And almost anything that thickens the interstitium in the lung can somewhat have this nodular appearance, because everywhere that you have two interstitial lines crossing, you have a little space where you can have a nodule. But if you have calcified lymph nodes, as you have in this patient, and calcified granulomas out in the lung, then you know you're probably dealing with miliary TB. CT is particularly good for identifying the miliary disease, particularly when it's in its more subtle form. It can be difficult in some cases to distinguish vessels from actual pulmonary nodules in miliary TB because they can be very similar in size, I think, if you can see here. But if you look out peripherally and you see nodular opacities out in the periphery of the lung, those shouldn't be vessels, because the vessels that are out in the periphery of your lung are very, very small and shouldn't really be visible to you at that level. So if you're looking for miliary disease, look peripherally. And then, of course, you know, it's important to look elsewhere in the body as well. And so this child on the right not only had miliary in the lung, but had neck nodes, had some hilar and subcarinal lymphadenopathy as well, that made the diagnosis much more apparent. And this is just a child that has that larger nodular form of miliary disease, but once again, very diffuse and very homogeneously distributed. Sometimes it's so diffuse and so homogeneous that it almost looks like pulmonary edema. And this looks like airspace disease, but it's actually numerous miliary nodules throughout the lungs. The other form of diffuse disease that you will tend to see is not miliary. Miliary disease is hematogenous dissemination, but you can get very diffuse disease caused by endobronchial spread. And in those cases, it may appear also nodular and miliary on your chest x-ray, as you can see on the left. But when you do a CT scan of these patients, you'll see that you have more branching opacities related to small nodules. This has been termed the tree and bud pattern, which is really characteristic of endobronchial spread in particular, not hematogenous disease. This is also not specific for TB. You can see it with some other, but it is very, very common with endobronchial tuberculosis. Then the progressive primary forms of TB usually cause very severe opacities in the lungs, lots of lung destruction, fibrosis, lymphadenopathy, eventually end up with bronchiectasis. And so they can be quite challenging to distinguish from other bronchiolitis obliterans that you might see with other types of viral infections. In this patient, I think you can see some peripherally enhancing lymph nodes in the mediastinal area here that may help you with the diagnosis, but sometimes imaging alone can't really make that diagnosis for you in this type of severe tuberculous disease. Sometimes the lymph nodes rupture into the pleural space or into the pericardium, and so you can get effusions in both of those areas. Pleural effusions are more common than pericardial effusions. And pleural effusions are thought to be often perhaps more of a hypersensitivity reaction. So they're going to be more serous transudates. They're not going to be exudates necessarily. And if you tap them, you usually won't grow anything out of there because of the fact that it's more of a hypersensitivity response. Pericardial effusions usually can happen either from direct extension from the mediastinal lymph nodes or less commonly from hematogenous spread to the pericardium. And pleural effusions generally occur, up to 6 months after the infection, and they slowly grow. So sometimes the patient's really not very asymptomatic. This patient came in with very minor degree of respiratory distress. So it was shocking to see this very large pleural effusion, and it was only suspected to be TB because of some subcarinal lymphadenopathy that was also detectable on this CT. These pleural effusions are sometimes self-limiting, so you don't necessarily need to tap them once you treat the tuberculous disease. But if you're wondering if you have a pleural effusion, then ultrasound is an excellent way to look for them. But they will look like the pleural effusion that you get with almost everything else. They will tend to be clear fluid. They may have a few septations, but largely they'll be non-loculated pleural effusions unless they're complicated by other types of infection. And very often, if you have a pleural effusion, there'll be some associated airspace disease. So widespread TB can affect a large number of places, right? So we have to do imaging, and our imaging varies according to where you really want to look. Obviously, central nervous system TB is critical to diagnose because of the severe complications that it can cause. And many of these patients will be very young in age. And interestingly, many of them will have an abnormal chest x-ray. So a chest x-ray in a patient that has neurologic symptoms is probably not a bad idea. Mostly the CNS TB occurs from hematogenous spread, although sometimes you can get direct extension to the brain or to the meninges from disease in the skull or in the middle ear. The most common manifestations are going to be meningitis, followed by focal parenchymal disease, and then can be complicated by vascular disease, which can then result in brain infarction. And the exudative gelatinous exudate that tends to form in the meningeal spaces in the CSF pathways can result in hydrocephalus in children, and that can be pretty rapidly progressive, can occur fairly early in onset after tuberculous meningitis. The localized forms of disease in the brain and spinal cord are generally considered to be tuberculomas. And you're really going to need elegant imaging to see these, either CT or MRI, and IV contrast is really important. They don't tend to calcify, and so you won't see them unless you give IV contrast and you can actually see the enhancement of the lesions. Ring enhancing lesions, such as these you see in this child's cerebellum, are typical, but you can also get solid lesions. And ring enhancing lesions are not specific for TB. You can see them with other diseases. Probably in my part of the country, cysticercosis is a more common cause of ring enhancing lesions, and they can look very similar, but cysticercosis tends to be associated with calcification frequently, whereas TB does not. They're usually small, and interestingly, the cerebellum is probably one of the more common places that we tend to see them in the brain. Meningitis is usually a more diffuse process, and you can get some hints from your non-contrast CT. You know, many times when we have a child who has neurologic symptoms and we're worried about the brain, we'll start with a non-contrast CT because you want to be able to detect hemorrhage in the brain. And if you give IV contrast, that can mask blood that's in the brain. So if you start with a non-contrast CT, look for increased density around the basal cisterns, because often you will be able to see that. But it's going to be much more obvious that with the prominent enhancement that you get in the basilar regions if you give IV contrast. And the findings are very similar on CT and on MRI, although MRI tends to be the favored diagnostic modality for the brain most of the time these days. So this is a non-contrast CT. Normally the spaces around the circle of Willis and around the basal cisterns in the brain are going to be low at attenuation. They're going to be dark. But in this case, you can see that they're brighter than the adjacent brain. You can actually see where the circle of Willis should be, whereas normally you wouldn't be able to necessarily see that on a non-contrast CT. So that's these gelatinous exudates just giving more density in that region. And then once you give IV contrast, you can see it lights up like a Christmas tree in all of those areas where you saw the higher attenuation. And so this is the inflammatory response related to tuberculous meningitis. This is much more profound enhancement than you will see with other types of meningitis, which might enhance a little bit around the brain convexities, maybe a little bit at the skull base, but not nearly this much as you will see in TB. On non-contrast MRI, you really don't see much with tuberculous meningitis. So you really do need to give gadolinium if you're looking for tuberculous disease in the CNS. And here you can see the profound enhancement once again around the basal cisterns and around the circle of Willis. And you'll also get enhancement in the spine. So the meningitis extends throughout the meningeal spaces, including in the spinal canal. And you will get this sort of nodular type of enhancement that you can see all along the spinal canal in this child with tuberculous meningitis. You obviously have to have very good quality imaging to be able to do this. Infarction is the dreaded complication, of course, of tuberculous meningitis, and is quite common because of the profound vasculitis that these patients can get. So you will see these bright spots within the white matter and sub-gray matter areas are all represent infarctions that can occur. This was a child, a 16-month-old, came in with some nonspecific symptoms of vomiting, had some eye deviation and some left-sided weakness. So they did a brain MR. This is a diffusion weighted image, and you can see this bright area in the basal ganglia, which represents a large area of infarction, which initially wasn't clear why this child had infarction. When they gave gadolinium, then they could see that there was this very profound enhancement around the basal cisterns, which was starting to be a clue. They got a chest x-ray to look for TB, and in fact there was kind of an ill-defined airspace opacity in the right upper lobe, not necessarily easily visible lymphadenopathy, so that also was a fairly nonspecific finding. But with CT of the chest, you could then see the airspace disease was also associated with ring enhancing lymphadenopathy in the paratracheal region. So So sometimes it takes a lot of imaging to finally get to the imaging diagnosis of TB. Hopefully your other tests will correlate with it and maybe help you to make that diagnosis a little bit faster rather than have to spend $1 million on doing your imaging. But this is sometimes the sequence that we go through to try to make the diagnosis, particularly if it starts with symptoms in the central nervous system. Abdominal TB is less common in children than adults, but we do see it occasionally. You can have lymphadenopathy, once again, is one of the important findings, but you can have lesions within the solid organs, particularly the liver and the spleen. You may get ascites. You can even get inflammatory masses within the bowel wall or within the omentum in rare cases. The lymphadenopathy can occur in a variety of areas, and unlike chest lymphadenopathy in children that doesn't calcify, the lymphadenopathy in the abdomen with TB does tend to calcify fairly commonly. This was a 12-year-old that came in with night sweats and a weight loss and some back pain. And initially they got a chest x-ray that's similar to that chest x-ray that Dr. Devine showed in the pregnant woman, because it showed some blunting of the costophrenic angle over here, looked like a pleural effusion, but no real visible lymphadenopathy in the chest, nothing to tell us that it was really TB until they got the CT of the abdomen to look for the cause of the back pain and saw these multiple confluent areas of ring-enhancing lymph nodes in the abdomen. They're often most prominent down in the ileocecal region, the right lower quadrant, and if you get pain from those, it can mimic appendicitis in some cases. But this is, you won't get this kind of lymphadenopathy with most other kind of inflammatory processes in the abdomen. It would be very unusual. So this is quite characteristic for abdominal TB. The solid organ disease is usually small little either microabscesses or tiny granulomas that you'll see in the liver and in the spleen. And they're well seen on ultrasound if you use a high frequency transducer, but often when we're doing ultrasound, we're using a lower frequency transducer so that we can penetrate more deeply into the abdomen and see broader areas in the abdomen. And you won't necessarily see these little hypoechoic nodular densities if you don't use a high frequency probe. So it's important if you're looking for tuberculosis disease within the abdomen, particularly in the solid organs, let your radiologist know so they can use the proper type of ultrasound probe to be able to see these well. And TB peritonitis is really quite rare. I think I've only seen a couple of cases in my career. It's usually an adhesive type of peritonitis, so often it will cause a lot of matting of the bowel. You can see in this patient that there's some bowel and mesentery that's all stuck to the margin of the peritoneal space. On ultrasound, it had a lot of fibrous adhesions within it, which is pretty typical of TB peritonitis. But really, you're not going to know that this is TB until you tap that, probably, because there are so many other causes of peritonitis. And finally, the other places that we tend to look for TB is in the skeleton. It's pretty uncommon there, so we don't see it very often. Maybe only 20% of the cases of extrapulmonary TB are in the bones. Generally, it gets there by hematogenous spread, and often we don't really know where the primary site was. Often the chest x-rays will be normal in patients with skeletal TB, but the general progression is similar to what you get with most caseating disease. You get granulomas that cause trabecular destruction, then will cause some cortical destruction, and eventually get out into the soft tissues. The classic place where we think of skeletal involvement of TB is in the spine, and it is a pretty common site, even though it's uncommon overall in this country. Generally, you will see intraosseous abscesses that cross multiple vertebral bodies in most cases, as you can see in this patient. And the other important finding that is pretty pathognomonic, as you see these very profound exudates that is caseating material that just spreads in the subligamentous area in the paraspinal region and gives you these very prominent paraspinal collections that you won't see with other types of vertebral osteomyelitis or metastatic disease or other things that might cause vertebral destruction in children. And we don't see many cases that are this severe. This is a very old case, but you can see the prominent paraspinal collections, even on a chest radiograph. You can see the multiple calcified lymph nodes in the paratracheal and hilar regions in this child. And you can see that there's been profound destruction of the vertebral bodies that, as it heals, causes a very angular, permanent kyphotic deformity in these cases. So fortunately, these kind of complications are really quite rare in the States, but can be very disfiguring and are much more common across the world. TB can involve the joints, and that's probably the second most common place that we tend to see it in the skeleton. It's usually just one joint, and usually it's big joints like the hips or the knees. And the main finding is going to be a joint effusion that's going to be similar to other joint effusions. So that fluid is going to have to be tapped. Ultrasound is pretty good. This is a picture of the hip joint with bulging of the joint capsule and a large amount of fluid in there. But that's no different than other types of septic arthritis. So you're going to rely on your clinical suspicion, your clinical findings, more subacute presentation usually for tuberculous arthritis as opposed to the more common septic arthritis in children. And osteomyelitis is really pretty uncommon. We don't see it often at all. It's usually going to be a solitary lesion in one of your bones, and it can happen almost anywhere. And once again, the chest x-rays are often normal in these patients, so you don't have any chest clues that it's TB. The skull is a frequent place, but you can also see it in the long bones, in the small bones of the hands and feet, and even in the ribs. There's really two types of pattern that we see in the bones. Some will be this cystic type of destruction with a very well-defined lytic lesion. And it won't be a very expansile lesion like you might tend to see with a tumor. It'll be more like a Brody's abscess type of appearance. And then the other form is more of a moth-eaten, ill-defined destructive pattern, which would be more worrisome for a more aggressive type of a process like a Ewing sarcoma or some type of chronic osteomyelitis. And then there's a form that happens in the hands and feet that's a dactylitis that is, I don't think I've ever actually seen a case of it in real life, but it can occur. It can happen in very unusual places. This chest x-ray was not too remarkable, but the lateral view actually showed some pleural thickening along the undersurface of the sternum. The patient did have a little bit of anterior chest pain, so they did a CT, and what they found was really a large area of destruction within the sternum with necrotic material that was extending both anteriorly in the chest and also into the retrosternal space and into the anterior mediastinum. So this is not a commonplace, but it just is a reminder that if you have a bone lesion that's not acting like your typical pyogenic infection, you should maybe think of TB. And Calvarial TB is another location. It's uncommon. It's most common in children. And almost always there will be a significant area of bone destruction in the skull associated with some subgaleal extension of the disease. So here you can see and so it will, since the scalp is thin, often you'll be able to see that protrusion in the scalp externally, but remember that you can also have extrusion into the subdural space as well, or the epidural space. And so it's really important to get brain imaging if you have swelling on the outside of the skull to make sure that you don't have intracranial disease as well. So I think that primary TB is a difficult diagnosis sometimes, even with all the types of imaging that we have because of the non-specific appearances. But if you look for that lymphadenopathy, that's going to be the key in many, many cases. And my rule is, unilateral hilar lymphadenopathy in a patient is, without significant lung disease is primary TB until proven otherwise. And you should restrict your use of advanced imaging when you have questions about whether you have lymphadenopathy in the chest, and it really becomes important for your determination of your management of the patient, or if you have confusing findings, or if you're worried about disseminated disease, then that's when ultrasound and CT and MR can all be very helpful to you. So this is kind of a broad overview, but I'm happy to answer questions. I do want to emphasize the point that was made by Dr. Devine and Dr. Armitage that, don't worry about the radiation. Even CT these days is much, much lower in radiation dose than it used to be in the old days. And although there are many reports about concerns about radiation-induced cancer when children have had a lot of radiation from CT scan, the fact of the matter is that the medical dose that you're going to get from CT is really quite low, and the value of the diagnostic information that you're going to get from CT almost always outweighs any risk that there is to the patient. So don't be afraid to use it if you have to. So I'm happy to answer questions.
Okay, thanks so much, Dr. John. We have some time for questions. Let me see. I'll join with Dr. John and put my camera on as well, and invite our other discussants. So we asked for questions from the panel physicians prior to you giving pre-talk to see if some things that they specifically wanted to discuss. And a couple of them I wanted to kind of circle back to. So the question was the most common X-ray lesions, and I would ask infants, children, and adolescents. Like if they were doing imaging, what would be the most common thing in each, common finding that you would feel that they should be especially aware of in infants, children, and adolescents?
It's pretty much the same in all of them. Lymph nodes, look for those lymph nodes. That's going to be your primary finding. And you may have some lung disease associated with it, but that lymphadenopathy is really the key. That's the most common finding, and it's really the most suggestive finding of it. Now, the more severe forms of Airspace disease can happen in young children and are fairly common. The sort of confluent pneumonia appearing look is somewhat more common, I think, in young children than it is in older disease. Children with older disease tend to have the more reticulonodular, even cavitary type disease that we see. But most of them, we're dealing with the more primary type of disease, and so it's going to be lymphobronchial or just lymphatic in many cases. Airway obstruction is going to be much more common in young children than it is going to be in the older children, just because of the size of the airway. Okay.
And I specifically, I wanted to hear you say that. We're so trained to believe that TB is cavities, and in children, it's almost never cavities.
Yeah, hardly ever cavities. Yeah.
I remember the first time I saw a cavitary lesion in a small child, and I was huddled with other pediatricians around the screen, and we were all just kind of oohing and ahhing because we just never see that. And one of the questions was, when do you do radiographic follow-up for patients diagnosed with the radiographic findings that are most suggestive of TB? So when you have patients who have lymphadenopathy, when is a good time to consider re-imaging for either, I guess if they're considering whether they're looking for response to treatment or just resolution, what do you usually see as the timetable for the best time? Because obviously if you repeat in a week, that's not going to help.
Yeah, you're going to wait a while Probably months, because actually the lymphadenopathy can continue to increase in size over the next month or two before it starts to regress, and that doesn't necessarily reflect lack of response to disease. So it's just sort of the natural progression of the lymphadenopathy. So I don't have a firm time frame for that, and maybe my pediatric colleagues are you, Lisa, have a better sense of that actually when you need to do it. But I know that doing it too soon is just going to confuse you,
Right.
and
No, I agree.
it's not going to be of value. Obviously, if the patient starts having more severe symptoms and you think you have a complication of
Right.
lymphadenopathy, such as airway obstruction, or pleural effusion or something like that, then that's the time to do it. But just for following up the lymphadenopathy itself, I think you should wait a while, if ever. I don't know if the patient is responding clinically. I'm not sure you need to get a follow-up.
I will say what I do, and then I'm gonna to drag Andrea into the discussion as well. But frequently, like between 2 and 4 months, you'll get some paradoxical worsening. So if you're checking the chest X-ray, a lot of times I'm looking for other like more infiltrative lesions and looking for those to resolve, but also looking to see if there's enlargement of the lymph nodes in the chest and if there's some concern with impending narrowing of some of the airways or impingement, for example. But a lot of times I will get a chest X-ray at the end of treatment. We stick to the standard length of treatment. I will repeat a chest X-ray just because for some reason we're always going into the winter time and they get the flu or they get some viral thing. They go into the emergency room and have a chest X-ray and everybody kind of freaks out. So they hear TB, but they don't get the whole story. They just heard TB and then there's a lymph node. And so then there's a lot of chaos. And if it's smaller, if it looks better than it did at the end of treatment, then it's easier to kind of discuss that with them that there's some resolving. But I just usually do beginning and end, and sometimes 2 months interim just to see what's going on in the meantime. Andrea, do you want to share, with your intrathoracic lymph node patients, how you tend to manage your imaging?
Yeah, absolutely. So I usually do get a 2-month film, only because rarely are those kids microbiologically confirmed. And if that lymph node is absolutely gargantuan in size, it certainly could reflect that the kid has immune reconstitution inflammatory syndrome. But it could also reflect, do we have the right diagnosis? I mean, as a TB person, very similar to Susan, I think that, all lymph nodes of the chest are TB until proven otherwise. But, in the absence of microbiologic confirmation, because let me tell you how excited our cardiothoracic folks are if I call them and I say, I think a patient has intrathoracic TB. Can you please stick a needle into this structure that is small and surrounded by important additional structures? Usually it's frankly the least invasive approach is to simply treat those children empirically. And then I always get a chest X-ray at the end of therapy, not necessarily because I'm expecting the X-ray to be normal to stop medications, because I know that especially with the children with intrathoracic TB, somewhere in the order of 50 to 60% of those at least will have, some radiographic anomalies. But I think it's important that you know what your new baseline is for that child. And then what I do is actually have the parents take a picture of it so they have it on their phone. Because in the old days, I would send them to Radiology to get a copy of it on disk. And then I realized, why am I doing this? I don't own any machine that actually has a disk drive anymore. And so I have them take a picture of it and I'll show them, I'll have them take a picture of their beginning of therapy and then their end of therapy. Because then if they don't show up to our system and they show up, I'm seeing them at Texas Children's and then they show up at Herman, we can get radiology reports from our sister hospitals, but we can't actually see the image. So I try to send the parents with that and in what is undoubtedly not some sort of HIPAA compliant fashion, but it's their own kids' medical records. So I think it's probably okay.
I am totally stealing that idea. That is an awesome idea. And when we have Dr. Kim Smith here with us too, is another one of our speakers. Kim, would you like to share kind of your approach to things?
Yes, hi. It was great to see such an excellent presentation by both speakers today. Wonderful cases and radiographs. I love Andrea's idea of taking a photo I do find kids love to see their x-rays and point out what's on the picture. So I do like to go over before and after. I've had parents in tears when they see resolution of the imaging. But the difference in kids, like you're saying, with both infiltrates and with adenopathy is it usually takes many months for you to see things get better. And my clinical experience is an x-ray at baseline. And then my plan is an x-ray at the end of therapy, unless the child has a clinical change where they become worse. And I have seen a few children where the lymphadenopathy has gotten much worse and even eroded into a bronchus, requiring some debridement. And those children are obviously having problems from the inflammatory reaction to the treatment and sometimes require steroid therapy to calm things down.
And I'd say for our panel physicians, we have another guest on our panel is Dr. Kim Skrovershek, who is one of our colleagues from DGMQ. So if you had any specific questions, any of our panel physician colleagues that are joining us today, if you had any questions, related to what your mission is with regard to, to being a panel physician, that's things that are specific to some of the, I guess I would say some of the administrative challenges of what you do, then she's made herself available. So I just wanted to point that out and say thank you. Going back to Dr. Devine, and Dr. Seaworth, I can't say that I've seen a typical lesion on chest x-ray for a pregnant woman. It's just the entire spectrum of TB. I just expect to see it. And I haven't seen any of these limited in pregnancy or expanded in pregnancy, but I will with Dr. Seaworth, who has seen, far more patients than I have, if she has any, has any thoughts.
No, I agree with you, Lisa. It can do anything. Something that we didn't note that is that both you and I have seen women over the last couple of years who have presented with minimal cough, normal chest x-ray, and positive sputum cultures for tuberculosis during pregnancy. And actually, we've seen that in non-pregnant women as well. So again, it doesn't seem to make any difference, but they have been largely, and I'm thinking probably all of them have been recent immigrants that have been referred to us as part of immigrant screening.
And then one question, so, I think everybody's all about the PA and lateral, and I just, seeing both, I'm med peds trained, so I'm seeing both children and adults. I always want a PA and a lateral. And so one of the questions was, are there additional chest x-ray views besides the AP that you use in children that you feel would add more to, what you see? So I know that I've done a lordotic in an adult. I don't know what forms of duct tape or perhaps, that it would take to get a lordotic on a child. But I would imagine that might be a little, that it might be useful, but I'm wondering with the thymus there and all the other structures, if Dr. John could share whether that's something that's even useful.
Yeah, not really. Sometimes you accidentally get a lordotic filming kids anyway, because they're arching their back and they're squirming around. So the best thing is to get a good PA and a good lateral if you can. Yeah. And I don't, the apical lordotics are to look at the apex, but in kids, we're not really dealing so much with apical disease, so necessarily. So I don't think pursuing that is usually very helpful, but getting good quality PA and laterals is a challenge in and of itself. So if you can get your radiologist to get you that, you're probably going to be fine.
I agree. I like that, the accidental lordotic. I will label that in some of my findings, but that pretty much was most of the questions that were offered up, and we don't have anything else in the QA or in the chat, and just a lot of kind of thank yous, and I want to say to both of our speakers today, thank you so much. I have to agree that Andrea Cruz was saying that she learned so much. You know, when you speak, Dr. John, I wanted to add my thanks into that. It's an outstanding talk. And for Dr. Devine, for what little, there just is so little out there. And I think she broke down the things that we need to be concerned about. But the most important thing is to let go of the fear of imaging. It's so important. You're never going to get to the answer, and you can protect babies from the womb on to, you know, adulthood by just having adequate imaging for them. So at this point, I think if we have no more questions, I will open it out to the speakers if you had any final thoughts. If not, we can turn it over to Chelsea to finish.
No, I just want to thank you for letting me do this, because I always learned so much from this too, because I see the pictures, but I don't always get the final story. I don't know what happens to the patient. And Kim's pretty good about filling me in on some of the severe cases, but I don't always have that longitudinal perspective. And so it's really interesting to hear about what happens to these patients. And I'm particularly interested to hear what happens to the mothers, because that's the side of TB that I don't see what happens before they're born.
All right. Okay, Chelsea, you want to bring us in?
Sure can. Okay, I want to thank all of our participants for joining us for our webcast today. And another big thank you to our panelists and our speakers. Always interesting hearing the stories and all the information you have to give us.